Catherine. I am a physiotherapist and I've been working in respiratory for almost 20 years now, so worked with a lot of breathless people and a lot of phlegm. So people don't realise we do, but it's all very exciting. But basically I have my own private practice under the name The Lung Mechanic, dealing directly with respiratory clients, but also a lot with breathing pattern disorders, with stress and anxiety and that side of things as well. And I also work for the Canterbury Clinical Network, helping run the pulmonary rehab classes there too. So, and a mum of four, a few different hats. Today, hopefully I won't bore you, but we'll be talking just in general, how do we breathe? Because you don't know what's going wrong unless you know what you're meant to be doing in the first place. And not many people breathe well, even without a lung condition. What is shortness of breath? Because that's very misunderstood as well. And then we'll have a little chat about the different chronic lung conditions that you're most likely to come across, and then how do we actually exercise this group safely. Feel free to ask things along the way if you'd like to, or wait till the end. So it's a lovely, pretty picture of the lungs, but basically our breathing system starts in the head and involves your sinuses, your nose, your larynx and your trachea, which is your main breathing tube, and down into your lungs. I think the easiest way to think of it is like an upside down tree, and the main breathing tube, where your trachea is the trunk, goes down into branches that then go into twigs, and then you've got your leaves at the end, which are the air sacs. And the nose is a very vital part of all of that, which I'll show you in a minute. But does anyone know how much lung, if you rolled out a lung in a flat, one bit high, do you know how much it would cover?
Tennis court, right?
A tennis court, yes. So there's a lot of lungs. Your lungs are huge. There's a lot of tissue, all packed. They start just above your collarbone, and they come down to where you feel your rib cage, down about here, and they basically fill up sort of about that much of your back, and then apart from your heart and a few major vessels and tubes and things, it's all lung. So they're a pretty big organ. So how do we breathe? Where are we meant to breathe from? What happens? Yep, nose. Always starts at the nose. Nose is so important. It's as silly to breathe through your mouth as it is to eat through your nose. Basically, that's what your nose is for. Your nose warms the air, it filters it, and moistens it, so by the time it gets into your lungs, it's just how it should be. We also have a gas called nitrous oxide in our sinuses, which is a really powerful antibacterial, antiviral agent, and you only get it when you breathe through your nose, and as you inhale through your nose, that nitrous oxide goes into your lungs and actually causes your blood vessels to open up, so you get more oxygen going into your bloodstream. So you actually get better oxygenation breathing through your nose than you do through your mouth. And this does change when you start having a lung condition thrown in there, but as a normal, basic, how you're supposed to breathe, it's through your nose. And there's a whole lot of stuff to do with pressure and things as well, but basically you need to use your nose. It's the best thing to use. The next bit down is your diaphragm. So we know about your diaphragm. That kind of cuts you in half, and it's kind of this way, a big umbrella. It's like when you breathe, it's like an umbrella on a windy day. It gets flipped inside out, so it pulls downwards and outwards, and that's what causes your lungs to expand. This is a model I made earlier. It's a very good teaching tool. Made it to take to my kids' class. But so your diaphragm's the swimming cap. It pulls downwards and outwards, and the lungs expand, and then it just relaxes back into place, and the air goes out of your lungs. So it just pumps, and it's actually a skeletal muscle. So it's the same sort of muscle that you've got in your biceps and in your thigh. And it's designed to be pumping all day, every day. Do you know where your backup muscles to breathing are? Yeah, so when you see people breathing from up here, they're using what we call your accessory muscles to breathing. So that's your chest muscles, your neck muscles, and some of your back muscles. Your diaphragm uses about 3% of your energy. Your upper chest muscles can use up to 30%. So if you think about these poor people with lung conditions, really heaving away with their upper chest, they're using a lot more energy just to breathe. Although a lot of people use their upper chest just to breathe, and they don't need to as well, but it's a whole nother talk. It's the most efficient thing to be doing from the nose and from the diaphragm. So as you breathe in, this area should come out, and as you breathe out, it just relaxes back in. And do you know how many breaths a minute you should do?
16.
About 10 to 12. And your breath out should be twice as long as your breath in. So you should breathe in, I mean no one's exactly the same, but you should breathe in about 2 seconds and out for about 4-ish, give or take. So it's quite because breathing out is just a relaxed process, it's just the diaphragm popping back into place. So, shortness of breath. I shouldn't have shown you that. What's shortness of breath? You'll know now, if you read it really quickly. How would you describe being short of breath, or why do people get short of breath? No. Yeah, no, it may not be. People think it's a lack of oxygen, but it's not. Most often it's not. It can be, but most often it's not. It's basic, the fancy word's dyspnea, but it's basically, shortness of breath is a sensation of difficulty with breathing. It's very much like pain, and the fact that everybody notices it individually, and you can look at someone and think you know how puffed they are, but only they can tell you how they actually feel. Does that, it's like with pain, you go, well, you should be that sore from doing that, but to them they feel in a lot of pain. Same sort of thing. But basically it comes down from a mismatch between demand and supply. But it's a very, very complex thing. There's a lot that comes into it. There's things like the stretch of the tissues and how full your lungs are. There's also a lot to do with your mind as well. So if you are getting a bit panicky, you're going to get a lot more short of breath, even if that doesn't match what the situation is. And in fact, there's a great quote, I think it's from the 50s, where the paper they were saying, a doctor that can give you one description for shortness of breath, you should trust as much as a tattooed archbishop handing out free tickets to heaven. So basically, it's not that easy. It's so complex. It's incredible, and once again, it's a day's talk on its own. And there is no direct link to oxygen levels. So a lot of people think when they're short of breath, my oxygen must be low. There is a very small portion of the population, and that's not even all the people with lung disease, it's within that group, that have low oxygen levels that will make them short of breath. But people can be chugging along with oxygen in the 80s and not actually feel very short of breath. And you can have perfectly normal oxygen levels and feel incredibly short of breath. So oxygen isn't actually the answer to shortness of breath. And it's really important that people understand that. And for the majority of people, it's not oxygen that drives our breathing. Do you know what tells us to take a new breath? What in our brain that says take a breath?
Carbon dioxide?
Yes, yeah, absolutely. So most people think it's oxygen getting low, but what it is as we breathe in oxygen, the oxygen gets used up to produce energy and provide energy, and we produce carbon dioxide. But it's actually the carbon dioxide increasing in our brain, where our brain goes, oh, too much carbon dioxide, can you get rid of it now please and give me a new breath? So a lot of people that are short of breath, it's because of that change in perception with your carbon dioxide, not to do with your oxygen. So just as a wee side note. But unless you can measure your oxygen levels, you're not going to really know. Okay, so that relative, very short version of how to breathe. We do it from the moment you're born to the moment you die too. It's a very handy thing to do. So the main chronic lung conditions that we run across, and within these there's a massive amounts of subgroups as well, but it's COPD, asthma and ILD, and I will explain what they are as we go. So COPD is chronic obstructive pulmonary disease. So it's kind of in the name. Chronic, long term. Obstructive means it's hard to get the air out. Lungs, it's in your lungs, and disease, you've got a disease. It can be known, it's sometimes known as other things, but not so much these days. They tend to be making it more COPD these days. But basically it's an umbrella term. You've usually got a mixture of things going on, and those main things are emphysema, chronic bronchitis, some forms of chronic asthma. Just because you've got asthma doesn't mean you've got COPD, and some people with bronchiectasis. So I'm not going to go too much into bronchiectasis because it's just an overlapping usually of those conditions. It's very rare to have purely emphysema or purely chronic bronchitis. There's usually a combination, but I'll tell you what those are as well. So some nice pretty pictures of the lung. So I can use a pointer. On that side it's a normal lung, and the alveoli, what I was saying before, are the leaves in the lung. So that's where the oxygen goes through into the bloodstream, and that's under a microscope. And with emphysema, you can see they look, so rather than being almost like a bunch of grapes, the tissue breaks down and becomes like a floppy balloon. And that's what it looks like. This is kind of like holy. The easiest way to think of it is if you've got some lungs that have got no issues with them, are like a nice fresh sponge, like a brand new sponge sitting on your sink. The water gets absorbed into it really easily, and you can squeeze the water out really easily. You leave that sponge on the side of the sink or forgotten about in the laundry for 6 months. Goes a bit hard and crusty. The holes might get a bit bigger, might absorb a bit of water, but it's really hard to squeeze it back out again. It's quite a vivid depiction of what your lungs are doing, but it's quite an easy way to understand and sort of really feel how it must be. So that's the emphysema, and there's some more pretty pictures. Sorry, just to gross everybody out. But that's a normal lung up the top and an emphysematous lung underneath. So it's not, you think of how you're going to feel if your lungs are looking like that. The chronic bronchitis side of it affects more the branches of your lungs. So if you think, as I said, if you're taking that tree again, so a normal branch is nice and open and the muscle's nice and thin. With bronchitis, it's that the muscle gets thicker or it becomes damaged and it gets thickened, and you also produce more phlegm. So you end up with a much narrower airway to try and breathe through. So rather than breathing through a toilet roll, you're breathing through a straw. Straight away, it's going to be a whole lot harder. And if you combine those together, you've got these narrow airways plus the air getting trapped in those alveoli that aren't squeezing it out very well, you can see how people become short of breath very quickly. And in fact, the easiest way to think about it, so I often call it hyperinflated. So if you take a really big breath in now, just and then just keep it there and try and breathe on top. And if you then try and exercise feeling like that, not very pleasant, is it? I mean, that's an extreme, over-exaggeration, but it is that kind of sensation. Your lungs are really full of air, because what they have trouble doing is getting the air out of their lungs. They can get the air in okay, but then it only goes, picture it's not working as well. So then they're trying to pump from here. So you can't even pump properly. Everything's just at a disadvantage. And we're going to talk about how you can help that with exercise a little bit later on. Okay, but that's just so you get an idea. Why do people get COPD? Most people know. Not everybody, but it's a good 85% of it is due to smoking, which you can see creates quite a stigma for these people. But cigarette smoke's the main one. Occupational dust and chemicals, there is a lot from exposure at work, so people not using masks and things in the past. Environmental smoke, passive smokers, so people that have grown up in households of really heavy smokers or worked in bars and pubs all that, when smoking was allowed inside. And pollution is actually one as well. But the big factor there that people don't talk about are genes. Because we all know somebody, uncle or granddad or great uncle's cousin or something that smoked 100, pack a day for 80 years and never had a problem. They've just got good genes, and you get the odd person that smoked for 2 years, 10 a day, and they've got COPD. And unfortunately, it can be luck of the draw. So yes, smoking is going to increase your chances, but you also need to have that genetic. Yeah.
What about vaping now?
Yep, vaping. Do not encourage it at all. Vaping's a really big, contentious area, and because from the smoke-free perspective, they see it as, and in fact, if someone's vaping and they were smoking, they actually call that person smoke-free because they're not inhaling a burnt product. Very. So from a harm, and when they talk about harm reduction, the research they did around it isn't actually around what actually is happening in their lungs. They took a whole lot of things and looked at economy and all these different categories and told these experts to rate what they thought was the most harmful and what was the least harmful. And because and vaping ended up at the bottom, so all of a sudden it's got less harm. And it's a whole, but you're basically inhaling a whole lot of chemicals that we don't even know what will do into your lungs, and there's definitely damage involved. So if someone's already smoking and it's a way of getting them off smoking, absolutely. But if someone's never smoked, do not let them vape. And in fact, they've shown they're actually starting to see it's becoming a gateway for people to smoke. So youth that would have never picked up smoking ever are vaping because it's considered okay, and then being led into smoking. So we're actually going to get increase in smoking potentially because of vape. So anyway, it's a whole nother Yeah. So it's good there's some more laws coming in around vaping at the moment. And the tobacco industry runs the vaping industry. You can never trust an industry that's trying to has the solution. Yeah. Anyway, and the other thing, I mean, I see so many people who just like, oh, it's my fault, I hate going to the doctor, they just all tell me off for smoking, and they say it's all my fault, and I feel embarrassed, and I just feel judged. We've got to remember, I can judge this generation as much as we want because they know better. They should know better. But in the previous generations, I mean, goodness, it was advertised by doctors. So, and it's an addiction. So I think we've got to be really kind to people about this sort of thing. And most they know they're not meant to be doing it, and they know that it's bad for them. And I think if we judge and tell people off, you're never going to get anywhere. But that's my on the side. And just when they have someone say, if you just acknowledge that and don't judge them, they actually really appreciate it. Right, so just as a reminder too, just because you've got COPD doesn't mean you don't have other conditions, but having COPD in itself leads to increased risk of heart problems. Thinning of your bones, osteoporosis, is getting repeat chest infections. Anxiety and depression is a huge part of having COPD, which you could imagine anyway. And diabetes and lung cancer are higher in those groups as well. So just sort of being aware that nothing's ever, which we all know, no one's ever just got one thing. The difference with asthma is that asthma is described as we've got an increased responsiveness in the airways to, that's a big boring thing, but basically your lungs react to things they shouldn't react to. And it's you're born with it or you develop later in life. And there are some occupational exposures that will give you asthma as well. But basically you get that same thickening. So it sort of looks like a chronic bronchitis type of airway. The biggest difference is if you take a reliever medication, your airways will go back to normal. Whereas with chronic bronchitis, you take your reliever medication, you might get a little bit of improvement, but they're never going to go back to normal. That change is permanent. But we do see a lot of chronic asthmatics that turn into COPD because the medications and the preventer medication wasn't around when they were younger, and so that repeat flaring up of the airways has actually led to permanent changes in the muscle in the airways. They end up in that chronic, what we call chronic asthma and permanent changes. So that's the biggest difference with your asthma and your COPD. Interstitial lung disease. Has anyone heard of this? No. So COPD and asthma are what we call obstructive diseases. So it means it's hard. They can get the air into the lungs, but they struggle to get the air out quickly enough, and so they end up getting hold of their tract. Interstitial lung disease is where the elastic of the lungs becomes less elastic. So the lungs become stiff. So so what happens is they find it hard to get a breath in and out. So they just have smaller breaths because they're just working with stiffer lungs. So it's like you've got that same sponge, dipped it in paint, let it dry, and then try to, it's just stiff. It's nice pretty pictures, which I think you see. Sorry, that's a bit boring too, but it's just showing you the different, so it's often a lot of environmental exposures. Asbestos and things lead to an interstitial lung disease. Silica, so there's people making silica benches. Some medications, a lot of people that go through some of the chemo medications. It's quite common with connective tissue disorders and autoimmune disorders as well, and post-infections and malignancy and things like that. So, and these people often have a very dry, irritable cough. So your COPD patients will have cough too. I didn't even write that down, but they have cough as well, but it's often a wet cough, whereas these guys will have dry, irritable cough. Small volume breaths. Their oxygen, so with COPD you have a whole spectrum of what oxygen does. Some people can be incredibly short of breath, oxygen's fine, others their oxygen drops into their boots. These guys will drop their oxygen levels very fast. So it's maybe not when they're first diagnosed, but definitely down the track. So you could just do a simple sit stand test and their oxygen at rest might be in the 90s and all of a sudden it's in the 70s. So they do change very quickly, and they do need to exercise slightly differently as well. So they're very short of breath, get very tired, often get very skinny because their bodies are working so hard. Does that, very brief. It comes up, there's like 100 different names and different things that go under it, but it's basically a restrictive lung disease. So, Why do we need to exercise people with lung diseases? They're short of breath and don't want to exercise. You know, why are we going to make them do that? How much should we be doing, and then how can we help facilitate that? Has everyone seen the downward spiral? We've probably seen it in other contexts as well, but in lung conditions, there's a really big downward spiral. Basically, it's hard to get the air in and out, so your lungs get full of air, and you start feeling really short of breath because you can't get the air in and out very easily. Who wants to do anything when they feel short of breath? You know, if you guys, whatever your activity level is, if I've gone for a run, and I don't do a lot of running, if I go for a run, feeling really puffed, and someone said to me, now you've got to go for another run, I'd turn around and look at them and go, no thank you, stuff off. But this is what these guys are like at rest. And then we're saying, no, you need to go and exercise. But what happens is, so they stop doing things that make them feel short of breath, because it feels safe. Being short of breath is scary. Our brain has no button, the only button it has for shortness of breath and discomfort in your lungs and in your breathing, the only button it has is feel more short of breath. It can't distinguish why you're feeling short of breath. It doesn't say, oh, you need to breathe out more, or you need to, I don't know, do something else. It just says feel short of breath. And when you feel short of breath, you panic. And when you panic, you get more short of breath. And it becomes a really vicious circle. So then they start limiting their lives and not going out and doing anything. And then their muscles get weak. Because if you don't do anything, you're going to get weak muscles. And you may lose weight as well. And then you try and do something, but the energy to do that, because your muscles have gotten weak, is twice as what it was previously. So then you stop doing that because it was just way too hard. And then you get more short of breath. And then you're staying at home on your own because no one wants to go out. And then it just keeps getting, your breathlessness gets worse. So you get stuck in this really vicious cycle of going down and down and down and down and down. And then you go with quite severe anxiety and depression on top of all that, and panic and all the rest of it. So what exercise does, helps with the upward spiral. So by getting people out and exercising safely, you increase the efficiency of their muscles and the strength of their muscles, and more efficient, strong muscles use less oxygen, and so you're able to do more. Then you're able to get out of the house, and then you have social contact, and then you're able to do more. And in fact, research has shown that so pulmonary rehab, which are those physical activities, and in fact just ongoing physical activity, is as effective, if not more effective, than taking inhalers. Number 1 is quitting smoking. Number 2 and 3, buying, is physical activity, and then taking the right inhalers. I mean, you need to be on the right inhalers as well, that's important too, but it is really, really powerful. And how much? It's the same. It's the same as everyone. What is the World Health Organization for everybody? What is it? 150 minutes of moderate exercise a week. Doesn't matter what condition you've got, that is the golden number. And moderate obviously just varies depending on what your moderate is, but I'll show you that in a second. And then 2 strengthening exercise, lots of strengthening a week. And it doesn't have to be in one blast. Everyone goes, oh, 150 minutes a week, oh, that sounds a lot. You go, no, it's about 30 minutes 5 times a week. Still sounds a lot when you're a breathless person. It doesn't have, they've shown you can do it in short bursts. Initially they were saying 10-minute bursts. Now they're saying actually incidental exercise, doing more just bits through the day, it all adds up. So it doesn't have to be one big bite, it can be lots of little bits, and actually just being active and keeping moving are the key things. But being active and keeping moving at the right level is that's the thing to convince people of. So does anyone know what the right level is? How you describe what the right, does anyone start with breath? Yeah, talk test, which is, in fancy terms, Borg scale. Has everyone heard of the Borg scale? So basically, moderate exercise, and this is for all of us, moderate exercise is when you are breathless but can still talk. Not like I'm talking, I need to do more exercise if I'm talking like this, but so you can answer more than yes or no. So if you're exercising with someone, you can have a short conversation. And so that is in the moderate to somewhat severe category of breathlessness. And so that works for no matter what your fitness level is. And if you are at that point just by getting up and walking 5 metres, then that is what, at a slow pace, then that is what you do. So, but you don't get to there and stop. That's where you exercise at. That is where you want your 30 minutes at. Does that make sense? If you get higher than that, you slow down or you stop and get your breath back. If you're not quite there, you need to up the ante. I have a lot of patients who, You say, how active are you? Oh, I walk my dog for an hour every night. Do you get breathless? Oh, no. No, I got a pace where I don't get breathless. So it sounds like they're being active, and they still benefit from that, but they're not really pushing themselves into their breathlessness, because who wants to get breathless? I don't even like getting breathless. No, but it's really, really important. So this is a lovely scale to use for people to gauge, where do you feel like you're sitting on the scale? Are you working hard enough? Could you be working harder? Are you working too hard? Do you need to stop and get your breath? And that's where the techniques come in to try and help them to do more. Because if you're all full of air and you're breathing on top of it like this, and you just tell someone to go do some walking or do some exercise, they're not going to be able to cope with it. They're just going to get more and more breathless and start to get panicky. So some really simple things you can do to help with that. This one is recovery positions. Does anyone know any good recovery? What would you tell a breathless person to do?
Lean forward.
Yeah, how?
Hands on the knees.
Often on their knees are on the table or a back.
Yeah, so would you put your hands or your forearms on your table or your knees?
I put my forearms or maybe a cushion underneath.
Yeah, so obviously I don't always have a cushion with you if you're out exercising, but absolutely. So forearms is better. Do you know why?
It opens up here.
No, it's probably even simpler than that. Because look at me. If I sit like this, you see what my hands are doing? If I sit like this,
Shoulders are up.
so it's a tension thing. If you do this, you can be relaxed. If you grip, you end up gripping, and you'll see them doing this. Why would you want to get in a forward-leaning position? If you think about how we breathe, what your main breathing muscle is, and what your backup muscles to breathing are.
It's relaxing the diaphragm.
Yeah, so it drops your guts out of the way. Gives you more room for your diaphragm to move, and actually kind of domes your diaphragm a little bit, so it puts it in a better position to be able to pump. And then your accessory muscles, so when you're really short of breath, they'll be working really, really hard. You remember these muscles use a lot of energy, and if your shoulders are free flowing around, they're having to load them up and down. So if you basically you're splinting them in place and allowing them to work more freely. And if you've got your hands soft, and actually, doing the same sort of thing, it's a much more relaxed way, whereas if you grip, you just throw tension all the way up the body. So if they're standing, I mean, you can do this, but a lot of them will, because you can't, this is really awkward. If you can do that, but otherwise, if you are leaning on your hands, just keeping fingers soft. So the main positions are like this. So these are the best positions. If you've got a wall, you can just lean. So that person leaning, I mean, if you tipped them the other way, they're basically leaning forward, but they're just leaning against the wall. Same sort of principle. That's your COPD and asthma. Interstitial lung disease is different. You don't need to sit upright. And that's because they get very, very short of breath when they lean forward. Like, very short of breath. So if you've got someone with, they've got an interstitial lung disease, you need to tell them to sit upright. So it's just, and preferably with arms supported, just once again, so they're not having to lug their arms up, their shoulders up and down. But it's because of the changes in the way their lungs are working, as soon as you put them forward, it just puts increased pressure on them and makes it really hard for them to breathe. So if you have someone with interstitial lung disease in your class, they'll probably struggle a lot with any of those really leaning forward activities. So it's just a wee caveat there to remember. There is the odd one out. It's not always about leaning forward for everybody.
So do most people know they've got that?
Yeah, they should know they've got it.
So if they come in and they just say, sometimes I find it really hard to breathe.
Yeah.
It's about what you get told.
I'd probably always automatically go towards doing, if they don't have a diagnosis, if they have a diagnosis, theoretically they should know, but I know there's always a lot of people there are people that don't. But I would probably always just go for the leaning forward, because it does tend to be the better one. And if they've done that and it's not helping, then say, how about you try sitting up? Does that feel better? You can only try. I mean, you're not going to knock them off their perch by making them lean forward, but they're just going to feel uncomfortable. And then, so the positioning's great, and then the next thing is using breathing technique. Now, does anyone know of a breathing technique to help reduce breathlessness?
Box breathing?
No. Good try. Box breathing is, I wouldn't do box breathing with someone with a lung condition. And box breathing is a technique for reducing stress and anxiety, and it's not something, so only with somebody who can actually hold their breath. So it's quite a specific exercise that a lot of people would have to be quite comfortable. Yeah, so not in an activity perspective. Yeah.
Purse lips.
Pursed lips. Right. Has everyone heard of pursed lip breathing? So pursed lip breathing, and now the main point of pursed lip breathing is to try and get as much air out of your lungs as possible. So as I said before, with these obstructive diseases, it's hard to get the air out. And so they're constantly battling to get the air out. So if you breathe out with pursed lips, so it's kind of like playing a tune over a beer bottle or a bit of grass when you're... sometimes I say that people don't know what I'm talking about. Maybe I only did that in Invercargill, I don't know. Nothing else to do down there. So it's, yeah, where you're trying, so it's not a whistle, it's a tight... And what that does is it puts the pressure to your lips, and because you're breathing out against pressure, it actually splints open your airways, because a lot of people with COPD have quite floppy airways, they close down quite easily. So by putting pressure, it keeps the airways open for longer, and it focuses them on a long exhale. The interesting thing is, this is also a technique we use in the stress and anxiety world to calm people down. So there's a twofold, it helps get the air out, but it also sends a signal up to your brain to say calm the farm. And the thing you need to tell people is that actually, if you keep breathing in, what's happening? If you're just focusing on breathing in, do you feel any better? No. If you get the air out of your lungs, what's going to happen? You're just going to take a breath in afterwards, aren't you? So it's trying to change that focus of, I need to breathe, I need to get more air in, to actually, if I get the air out, I can get a good breath in. So sometimes it's just flicking. So so the best thing to do is combine the two, pursed lip breathing and positioning. But pursed lip breathing you can use for recovery, and you can use it for exercise. And you see the All Blacks doing it. They walk around, what are they doing? They're opening up their chest, they're doing long breaths out to recover. So it's used across the board with recovery, but particularly with your obstructive patients, because you're giving them longer to get that breath out, which they struggle with, and it's going to calm them down. So even if someone's getting panicky, you tell them to sit forward, breathe out. Breathe out. Don't say calm down, because they'll want to hit you. You say calm down. We all want to hit someone if they tell us to calm down. Just say, focus on getting the air out. Not a, but a... If they can, back in through the nose. But if they can't, just go on through their mouth, and then when they feel like they can, then try and get it in through your nose.
Should they try and make their breath longer?
Yeah, absolutely. Make them as long as they feel. So, and you'll probably find initially it'll be a bit short, but as they take, it gets longer and longer. Yep. You want to make it as long as you can. Yeah. You don't want to be like completely empty, but yeah, as long as you feel, yeah, definitely, as long out as you can. So yeah, you can use it at all times. It's great for panic, great for when you're exercising, and it's great for recovery. Simple, and it works for your interstitial lung disease patients too. Even though their mechanism's different as to why they're breathless, it's the same with anyone. If you get the air out, there's room for air to get in. It's as simple as that. Because our brain keeps telling us to breathe in. Has anyone got any other ideas they've heard about or have thought about with people working with breathless people that might help?
Someone's suggested this puffing with this.
Okay, so the huffing and the clap, that sort of self-clapping, that's about chest clearance. So that's about getting phlegm off people's chest, and it's more of it's not really an exercise type thing, it's more something specific you'd do if you had phlegm as an issue and you're trying to clear your chest. So to me, from a scope of practice type thing, that's more of a respiratory physio teaching somebody how to do that kind of thing. But if they're already doing it, you can encourage them to do it, but it's not something you do during an exercise class. Unless they were full of phlegm and needed to clear themselves so that they could then participate. But yeah, if they're having issues with phlegm and having trouble clearing it, then probably getting them to go and see, I mean, there's respiratory physios at the hospital, but they probably have to go through their GP to get that, or they can't see them privately if they want to. But yeah, so there's some really good things that you can use. So pacing, I mean, that makes sense. Just don't go flat out. A lot of these people will go hell for leather and then usually hold their breath while they're doing it. Stairs is the classic example. I feel awful when I get to the top of the stairs. They probably held their breath all the way up. So trying to get people to pace themselves. So there's simple pacing like you walk 2 steps to breathe in and walk 3 or 4 steps to breathe out using your pursed lip breathing, particularly up the steps. Or it could be that they know that that's another way of pacing is they know they can quite happily handle a 15-minute walk, so let them do their 15-minute walk, and know when to have your breaks, or have your break then if you're trying to increase it, have a break a little bit earlier. Because a lot of people think, oh, if I'm almost done, if I just keep going, I'll get there, and then they really short of breath at the end. So trying to understand that stopping earlier and breaking the task up, no matter what the task is, even if it's housework, and having a break in between is more important than thinking you have to get it finished and complete it, and then feel lousy at the end. So taking your time and having more rest is going to enable you to do more overall. So, yeah. Fan therapy. Has anyone heard about just using a fan? So anyone feel, whenever they feel a bit, a little bit claustrophobic, it's a hot room and you just want to get outside with the fresh air? And then you get a lot of patients who get really sick and they go, oh, but when I go to hospital and they give me oxygen, I feel heaps better. What they've shown is there is a few people that need the oxygen, but it's actually the cold air on your face. So it triggers your trigeminal nerve, which is one of your facial nerves. It sends, when it has cold air going over it, it sends a signal up to your brain to calm down and to reduce your shortness of breath. So fan, if you're doing an exercise class, having some fans available, or telling people to get their own little portable fan, just a little handheld one, or even just good old fashioned, I had someone using an ice cream lid, that was their fan. If they're getting a bit short of breath and are struggling to kind of bring themselves down, that cold air on your face, it's not just psychological, it's actually a thing that's happening in your brain to calm them down and to help them feel less short of breath. So it's a really valuable, really good tool. Walking aids, a lot of people don't like using walking aids, it's very embarrassing, but actually for very, very short of breath people, a frame or something, even if they don't need it for a balance perspective, just give them something to lean on and they can get their breath back, and they can do more. A lot of them you'll know, because they'll say, I love going, I can walk around the supermarket and I'm okay because I'm leaning on the shopping trolley. It's that same thing. So they're putting themselves in those forward leaning positions. So walking frames and aids, if you've got someone that's in your class that is struggling, can be hard to get your head around, but if it means you can get out more and do more, then it's completely priceless. And they have them seats, they can stop them in breath, it's really important. Even sticks, sticks aren't as good, but I know I have a few people that don't want a frame, but they quite like the stick because they can stand and just, have a wee lean and look through the window at the shops and just feel like they've got a little bit more support. Not essential, but it's definitely in the toolkit. And blow as you go is just basically meaning breathe out as you do the hard thing. Because what you'll find again is we'll do some sit stands or do it, and everyone just holds their breath, keeps going. Or I'm lifting weights, so and you're going to get really, really short of breath because you're putting a lot of strain on those chest muscles, and then you're trying to work the chest muscles as well. So breathing out as you do the hard bit. And that tends to put your breathing back into pace with what you're doing, so you're less likely to get short of breath. Or walking upstairs, breathe out as you go up a step, and then have a pause and breathe in, and then breathe out as you go up a step. For those really, really short of breath people. So just thinking about that timing, and are you breathing on or out when you're doing an activity?